Hello everyone, my name is Dr. Eleanor Egan. This is brought to you by Melbourne IVF and we're going to be talking about reproductive conditions this evening. Feel free as you're logging on to fire out some questions. I'm going to be trying to go through these in a fairly systematic manner, but I'm more than happy to divert to anything that's specific to your wants or needs. So a little bit about me. I'm an obstetrician and a fertility specialist with Melbourne IVF. And I consult out of the Epworth Freemasons and also deliver babies there when everything goes successfully. So I think a good place to start before you guys fire out any questions is just to talk about what's actually needed to get pregnant, because it's such a complex system that involves both a man and a woman, so it's involving two people, and everything has to go right for someone to be able to get pregnant. So to start with, we actually all start up around the brain. And there is a pituitary gland that is sitting underneath the brain, and that's what's controlling most of our normal hormones. And any factors that can impact that can impact the way that you ovulate. And what happens next is the pituitary gland sends out messages to the ovary to tell it to ovulate. The ovary receives those messages, grows the follicle, releases the egg. That egg then needs to pass down the fallopian tube to the uterus. And then once it hits the uterus, it then needs to be able to meet with the sperm. So the sperm needs to be mobile, functioning in the right place at the right time. And then it needs to have the right environment to be able to implant into the uterus and to develop into a growing pregnancy. So from there, it has to undergo multiple cell divisions, and it has to get it right every single time with the chromosome. So you can imagine that at any single point of this process, if something doesn't go quite right, it might affect your fertility. All right. So if we've got no questions to start, I'm just going to keep on talking, and I'm going to talk to you about the particular issues that can happen at any of those points. And I'm going to focus mostly on female fertility tonight, as my colleague Hassam El-Zaini did an excellent talk purely on male fertility. And another colleague, Dr. Joseph Scroy, focused on miscarriage and pregnancy loss. And so those are big topics in themselves. So if we're starting back again at the brain, at the pituitary gland, so what can actually affect things and make things go wrong at this point? So if you have any sort of a chronic medical illness, or if you've had significant weight loss, then that might actually inhibit that pituitary gland from sending those messages out to the ovary. And so things like, well, really anything. So I'll see people with severe renal illnesses, cardiac illnesses, and that will actually prevent their brain from sending messages to the ovary to ovulate. And it's actually a very good system because it's the body's way of protecting itself. We see other issues in that area where the messages that are being sent out to the thyroid can actually be abnormal. And so if you have an abnormal thyroid hormone, either being high or low, that then interacts with the way that you ovulate and prevents ovulation as well, or can make you ovulate irregularly. There's another hormone that's produced there that's called prolactin, and any issues with, in particular, very high levels of prolactin, which can be caused by a small tumour, can also prevent you from ovulating and affect your ability to get pregnant. Now, the good things with both the thyroid and prolactin abnormalities is that they're relatively straightforward to fix, and by fixing them you can then go ahead and get pregnant. So with thyroid hormone, if it's too high there's medication, if it's too low there's medication, and both of those can really improve your ability to get pregnant. With prolactin's a little bit more difficult because it's sometimes caused by a microtumour in the brain. So it's not a malignant tumour, it's a benign one, but it's causing this hormone. And so sometimes there's a surgical process that people have to go through if that's the case. And that would be following an MRI scan to check. Got a question from Matthew about the difficulties of falling pregnant with endometriosis, and I'm definitely going to get to that because endometriosis is going to be one of the biggest medical disorders that affects your fertility. So what we might do is talk about that right now and then come back to the other ovarian issues. So endometriosis is quite a complex condition and it can be a little bit challenging to understand because you can't it's not very easy to visualize it if you don't actually see it during a surgery. So endometriosis is where the lining of the womb, which is called the endometrium, and has endometrial cells. And we don't know the exact causes of what causes endometriosis, but there's a few theories out there. And so these cells that normally should be safely within the womb are actually in areas outside of the womb. So around in the pelvis, sometimes in the ovary causing cysts, sometimes in the tubes causing obstruction. And what they do is that every month that you have a period, you're effectively growing these cells, like you're growing the endometrium, and then when you have your period, you're shedding it. So that's happening month on month, and it sets up a big inflammatory process which can inhibit your ability to get pregnant. And it does that in a few ways. So if it's within the ovary itself, and you can see a big cyst, that can actually affect what's called follicular genesis. So that's where the way that the ovary and the egg goes from being an immature egg and gradually grows and matures, so it's a nice big plump follicle, and then releases that egg. So that can be impacted, and the quality of the egg that's then released can be reduced. Then we come to the tubes, and obviously if there's scarring in the tubes from endometriosis, then that egg may not be able to pass down safely into the uterus. So you might be not able to fall pregnant because that egg physically can't get to the uterus. And then the second way is that a really interesting thing is that we see the inflammatory cells and the immune cells that make up a normal endometrium are actually worsened in women with endometriosis. So there's more of an immune response. And so the theory behind that is that a pregnancy might get there, but it's not a friendly environment for it to implant. And so an important thing to know about with endometriosis is that if it's surgically resected, then that then can take away that inflammation process. And so a woman's natural pregnancy rate is significantly increased. And to a lesser extent, but her success rates with IVF can also be increased. And so how do you know if you've got endometriosis? And that's also one of the really complex areas of it, because a lot of people know that it causes period pain, and some people get absolutely dreadful period pain, can't go to work, can't go out of bed. But a lot of other people don't get period pain that badly, but it inhibits their symptom is that they can't get pregnant. And it looks like it's otherwise unexplained because they're ovulating, there's normal sperm, everything else is happening normally. And if we see an ultrasound, and it can only detect severe endometriosis but not superficial endometriosis. And so for some people, the only way that you can pick up your endometriosis is by doing that keyhole surgery. And so I think an important thing to know about is if your fertility problem is or has been classified as unexplained, so normal ultrasound, tubes are normal, sperm's all normal, you're ovulating. If you don't have a lot of period pain, your risk of endometriosis actually is 40%. So background chance of having endometriosis is about 10%, so 40%, so that's really considerable. And if everything is looking normal and your fertility issue is otherwise unexplained, if you've got quite painful periods, the chance of you having endometriosis actually goes up to 80%, so that's a huge amount. Looking more about how it affects the tubes and other tubal conditions, because the tubes being blocked or there being a problem with that egg being able to pass down to the uterus is a significant cause of fertility problems. And endometriosis is one of those ones that can either scar it completely up or prevent that from happening. But there are other causes, and the main other cause to be aware of is some sort of infection or some sort of inflammatory process, and chlamydia is the biggest culprit. Unfortunately, nowadays we're pretty good and people are pretty onto it with getting themselves tested and treated, but sometimes you can have no symptoms, and so people can have had that happen and not know about it. Or you can have other sort of lower grade inflammation or other infections within the pelvis. And because the tubes are so fragile that any sort of inflammation just makes them stick together. And unfortunately, look, a question that people ask me all the time is, can't we just cut that bit out? And that would be great if it was just one part, but it's usually the whole length of the tube has got some sort of disease process that's making it not work. Sometimes I'll do a laparoscopy and actually check to see whether those tubes are open or not, and a woman's had no endometriosis, no history of any infection, and they're blocked anyway. And so we don't ever find out the cause, but some sort of mild inflammatory process is probably the culprit. Now, the good thing is that this is exactly what IVF was designed for. So IVF is designed to get the egg and the sperm in the right place at the right time, and it was primarily used for women who had blocked tubes or for whatever reason. Now, another issue that we can see with tubes is that if they're blocked, but then they've got some fluid in it, and that's a condition that's called a hydrosalpinx. And hydro just means hydro is water, and salpinx is another name for the tube, so water in the tube. And what can happen there is that, one, the egg's not able to come down, but it actually also impacts the success rate even if the other tube is okay, or if you're doing IVF, because some of that fluid that's in there can actually migrate down inside the womb where the embryo is supposed to go, and it's actually poisonous, effectively. And so it reduces your IVF success rate by about 50%. And unfortunately, those tubes, because they're causing major problems, they need to be either removed or they need a clip put on them so that they're effectively blocked off and not able to poison the uterus. Another major cause of fertility issues, and usually the easiest one, and we've just got a question up about it now about PCOS, is ovulation dysfunction. And there are quite a number of issues that can cause it, and we'll talk about the most common, which is polycystic ovarian syndrome. So PCOS is the most common hormonal disorder that we see in women in the reproductive age. And it is one that for fertility affects your ability to get pregnant because you're not able to release the egg. So going back to when we were speaking about the pituitary gland in the brain, where that's then sending messages to the ovary, and then the ovary then is supposed to send messages back to say, yep, we've ovulated, all good, we're ready to start that process again. That messaging system is just interrupted. And it's a really complex interaction with hormones that cause that to happen. And it's a little bit misnamed as polycystic, and people go, oh no, I've got cysts in my ovaries, and they're not true cysts, they're actually polyfollicular ovaries, or lots of little follicles that all have eggs in them. And again, there's some genetic causes about that. We quite commonly see it in families. It interrelates to weight, so any sort of fat tissue also has hormones in it, and they can then interplay and make it worse. But they're not all people that have PCOS have problems with their weight, and in fact some are actually the opposite and are a little bit underweight. And so the good thing about PCOS is that it is the easiest and the most successful in being able to treat, because it's not an issue with the quality of the egg or getting the egg in the right place. It's just a matter of releasing the eggs. The eggs are there, they just need to go through that hormonal process. So if someone is overweight, then losing a small percentage of their weight, even a couple of kilos, even changing things like that, can then get their hormones started again. There is a diabetic medication called metformin, which changes the way that a woman who insulin resistance and PCOS are very closely related. And so just by being on that is enough to help some women ovulate. But more commonly, we need to do a treatment that's called ovulation induction, which is usually tablets, sometimes injections. And those tablets are effectively doing that job of that messaging system. So they're telling the brain to tell the ovary to ovulate. And they are really successful in the vast majority of women who have PCOS, as long as there's not another underlying condition, because just because you have one issue doesn't mean there's not others happening at the moment. And I have another question from Julie about, is there a cure or a way to fix PCOS? And the short answer is unfortunately no. It is considered a lifelong hormonal condition. However, there are things that you can do to improve your symptoms. So again, weight management, although it's always much easier said than done, and I think that if it was that easy, then no one would have a problem with it. But managing your insulin resistance. For some women, we can actually do a surgery, which is called laparoscopic ovarian drilling. And that is look, I usually reserve that for people who aren't responding well to the medications, because they've essentially got too many follicles, there is too much of the hormone that's preventing ovulation. And so by doing keyhole surgery, and it's literally just putting a few little holes in the ovary and burning out some of those eggs can then make a woman more susceptible to the hormones and make her ovulation come back to normal. But it is a lifelong condition, and it is associated with some other medical problems that that people need to be aware of that I won't go into too much detail now, but it's not one that you can ignore. And another question that I have from Megan is it the same as endometriosis? No, two very different conditions. Sometimes women can have both conditions. So again, endometriosis is where the cells of the endometrium are other places in the pelvis and causing a sort of a toxic inflammation. Whereas polycystic ovarian syndrome is a whole body metabolic disorder where the hormones aren't communicating properly. And that's preventing someone from ovulating. So usually a woman with endometriosis is ovulating normally. It's just that ovulation process and the development of the egg might be affected. The egg may not be able to get to the uterus, and the endometrium, the lining of the womb, may not be a healthy environment to receive a pregnancy. So other disorders of ovulation that we see, and look, a lot that I see is that it comes a little bit too early, a little bit too late. Maybe the hormones that are produced by it aren't quite there, and those ones are also things that can be treated. Another question I've got from Megan is that, and I'm not sure if your meaning is endometriosis lifelong or not. Endometriosis is, we can treat it surgically, and for some people they can be completely cured of the condition because it's spots of tissue in areas of the pelvis where it's not supposed to be, and it can, depending on the severity, it can be successfully completely removed, and then potentially you may never get it again. However, in saying that, there is a risk of it growing back. And about 15% of women who have surgery for endometriosis, typically more for pain than for fertility, but about 15% will find that it grows back and they need to have another surgery about 5 years down the track. So a good way to manage endometriosis when you're not trying to get pregnant is to actually suppress it. And so it's related to periods, so medication that helps to suppress a period and suppress your hormones it will also be really helpful for endometriosis. So that includes being on the oral contraceptive pill or a Mirena IUD is also really good. And I've had a great next question about adenomyosis. And so adenomyosis is an even less well understood condition in the general community than endometriosis. I think we're getting a really good, some really good coverage and some really good media coverage about endometriosis, so people are becoming more aware. But adenomyosis is a tricky one. So adenomyosis is actually within the wall of the uterus, and it's these same cells that should be within the womb, and they're growing within the wall, and over time they make it in from a nice structure, and they gradually grow the wall bigger and bigger and bigger, and they can cause terribly painful periods. They can cause really heavy periods, and really importantly for fertility, when it gets bad, it's changing the surface area inside the womb, and it changes the area that pregnancy will want to actually implant. And if it's not a healthy area to implant, then the embryo won't implant and you won't get pregnant. And so it does make things quite difficult for some women because it is a bit challenging to treat. So it's not discrete in most cases, so it's not just there's one spot and we could surgically take that out and then that's the end of it. It's usually throughout and it's spread diffusely, so the only way to actually completely get rid of it would be to do a hysterectomy and take out the uterus, and that's great for women who are not wanting to get pregnant or have finished their family. Excellent treatment, but obviously if you're wanting to get pregnant, that's going to be counterproductive. So for some women, we try to get them pregnant with endometriosis, but if it's really bad and a very enlarged uterus, there's a treatment where you can suppress these hormones in the pituitary, effectively asking someone to go through menopause. And we may even do that for 6 months, and it's not a treatment to undergo lightly because there are a lot of side effects. You're effectively very suddenly in menopause with hot flushes. But for some women, it is successful in being able to shrink your uterus down so that it's a good environment to implant an embryo, and it certainly for some women does increase their chance of success with IVF. Typically for these women, I'd ask them to have embryos already frozen so that we can then straight away at the end of that treatment go, right, we'll put this one back in before the adenomyosis has a chance to grow back, because unfortunately that treatment is not a permanent solution and it is going to gradually come back over time. All right, I'm having a look down through the additional questions. So look, we've got some questions about natural killer cells, which is a great one and a very controversial one, and I will address that. And also one about cysts in the ovaries, and I might just tackle that one first. So we'll go back to the ovary for a little bit. Cysts in the ovary affecting the quality of the follicles or the eggs. So it depends on the cysts you're talking about. If it's just a polycystic ovary, no, not so much. But if it's a big cyst, so we've got lots of benign cysts that can be there, and also malignant cysts that can be there. And yes, they can, because by being there, it affects that process called follicular genesis. So how the egg goes from being immature and the follicle with the egg inside it gradually grows over time. And that process is really quite important, because if you do that too quickly or too slowly, or if there's something abnormal about that process, then the quality of the egg that's produced can be affected by it. So if someone had a large cyst in the ovary and they were having trouble getting pregnant, then often just removing that cyst can then improve the way they're producing the egg, improve the quality, so that then the chance of being able to conceive naturally is actually improved. Before I tackle natural killer cells, I want to talk about a little bit more about the ovary. And a big one, and the big scary one, is premature menopause or premature ovarian insufficiency. And that's where you run out of eggs too early. And typically the average age of menopause is 50. And if you run out of eggs before you're 40 and your periods stop and you've got no eggs left, that's called premature ovarian insufficiency. And it's one of the hardest ones, because it's not treatable in quite a lot of cases. So the reason why this happens is sometimes it's genetic, but in a lot of cases we don't find out the reason why. And it's just the way that a woman's had all of her eggs since before she was born and cycles through them every month, and the rate at which you lose your eggs differs between person to person, and there's a little bit of genetics in play that's involved with that. Smoking will speed it up a little bit. If you have some surgery to remove, say, half of the ovary because of an abnormality, that'll speed it up a little bit again. But most of these causes are actually unknown. And unfortunately, if there's no eggs there, there's no way of us creating more eggs. 10% of these women will ovulate naturally again, and 5% will actually be able to conceive with their own egg in their lifetime, but the vast majority will actually need to use donor. All right, I want to tackle one more topic about abnormalities within the uterus first before going to natural killer cells and the endometrium. And so that topic is fibroids. And I think that's a really important thing to know about, because fibroids are so common. If we scanned absolutely everyone, eventually about at least 50% of women will have a fibroid in the uterus. And so what is a fibroid? So the uterus is a nice muscle, and fibroids are these typically benign growth, sort of a fibrous growth within that wall. And there's a few different types, and some of them affect fertility and some of them don't. So if you can imagine, we've got a nice little area for a pregnancy to be. If you've got a fibroid bang on top, it's not affecting this area here, so that's not going to affect your ability to get pregnant. Whereas if you've got a fibroid that is right in the middle, in the cavity, that's definitely going to affect your ability to get pregnant, because the embryo can't actually implant there. It's not a friendly area. Surgical treatment for this is very, very successful with low complication issues for future pregnancies. If the fibroid is inside the wall of the uterus, then it depends on the size and it depends on how it's then impacting on the cavity. So if it's less than 5 centimetres, if it's not putting pressure and squashing the cavity at all or deviating the cavity, then it's usually okay. Above 5 centimetres, it can start to elongate the cavity. So we're making the surface area bigger. A bigger surface area is not friendly for an embryo to implant, and those are typically the ones that I would suggest removing. And a fibroid, no matter how big it is, but if it is jutting into that cavity and changing its shape, then that's potentially causing a problem as well, and that's one that's probably better off being removed. But going through that surgery, so it's surgical treatment, does have risks associated with it and does have implications for future pregnancies. So essentially, if the fibroid's on the inside of the uterus, we can just nicely shave it off, just to make that surface area the same as what it should be. But if it's in the wall, we actually need to make quite a large incision to be able to remove it, and then that's stitched up. But after it's stitched up, it's got an area of weakness, and it's the equivalent of having a couple of cesarean section scars, so that it's a rare but a very serious complication that during growing pregnancy that area of weakness can actually split or come apart, and that's a critical emergency. So I think that at the end of the day, you shouldn't be taking out fibroids that aren't causing problems, and you should only be removing ones that are actually giving you problems. All right, and so now we'll talk about the endometrium. There's quite a number of factors, and in fact a lot of factors within general health that can affect the quality of the endometrium, and it's affected by estrogen. So we get more and higher levels of estrogen from fat tissue, so that can make your implantation worse. It's affected by diabetes, so high blood sugar levels affects the quality of the endometrium, affects implantation, increases the risk of miscarriage. And then there's a lot of immune factors which are really important, and unfortunately it's probably the emerging one of the most important areas of fertility treatment, but it's also the poorest understood. And natural killer cells is one of the really important and probably more famous immune conditions. And it's controversial because a lot of the initial studies that were done were suggestive to say, hey, we've got these natural killer cells, we do a test, we do some treatment, we're going to improve someone's success rate. And then people said, great, that looks good, let's validate those studies. So we'll look at more women to see whether that's a true abnormality and whether the treatment truly works. And then unfortunately, these subsequent studies that were done showed that actually it doesn't seem to make as much of a difference as what we were hoping for it to do. And in fact, it potentially doesn't make a difference at all. And unfortunately, one of the medications that's used for treatment of natural killer cells, so the treatment involves an immunosuppressant and also a blood thinning medication. So prednisolone, the immunosuppressant, may actually make things worse for some women. So I'm always cautious with using it straight off the bat unless someone's had recurrent implantation failure, in which case it's worthwhile trying the more controversial treatments if nothing else is being successful for you. And my personal opinion with it is that natural killer cells are not the whole story. So definitely immune factors are critically important, but the tests that we have available, and some of the problems with the studies is that the tests we're using all sorts of different numbers to see what's normal and what's abnormal. There's multiple other immune cells there that we don't test, but they're probably and potentially just as important. And you need to have a level of immunity there, and your body needs to then suppress your immune function to be able to have that embryo implant. And what's happening with that suppression, we don't actually have a test for, because we can't test someone as they're getting pregnant. We can only test them outside of pregnancy. And so, my opinion is that they're not the full story. So the question that was asked is that if I have natural killer cells, is it vital that it's treated? And I would be cautious if you've not had IVF before and this is the treatment off the bat. And in particular, you've got to individualize it. So if you've got another cause for your fertility problems, like a sperm problem or your tubes are blocked or you've got endometriosis, then you've probably got a better answer as to why you're not getting pregnant. However, if you've gone through lots of cycles, you've had everything else excluded, you've got these great embryos and it's still not working, then I think it's more reasonable to be starting to think about, okay, well, look, something's going on. And maybe we don't have a great test for it, but it's worthwhile trying something. In terms of the actual treatment for natural killer cells, so clexane, which is the blood thinner, very benign. It does make you bleed more, but unless you actually got into an accident, it's relatively safe to take. But the prednisolone, which is the immunosuppressant, and look, we do use it for lots of other conditions, immune conditions that people need it for, but it does have side effects. And one of those side effects is that it increases the chance of cleft lip and palate by 1 in 1,000. And look, that's very small. The baseline chance is about 2 in 1,000, but it's not nothing. And it also can cause quite significant weight gain. People find that if they take it at nighttime, it can give them nightmares. It can cause fluid retention. It can make your blood sugars worse. And if you haven't had any IVF treatment before, there's a risk that taking it may actually make it worse rather than make it better. So I think that that's a consultation you'd have to have with your fertility specialist, and whether you'd rather try your IVF without it first. And then if that's not working, then it's very reasonable to use the treatment afterwards. And I'm going through my list, and that's most of the female causes. I think it's really worthwhile mentioning some of the sexual causes. And they can be either male or female, because obviously if you can't have sex and you can't have sex at the right time of the month, then you're not going to be able to get pregnant. And the good thing about this is that these are also quite readily treated with fertility treatments. So from a female side, there's a condition called vaginismus, and it's not common, but it's where the muscles around the vagina to the slightest stimulus will actually clench down. And there's not necessarily any background history that's caused it, but these women find they get their period and go to use tampons and can't use them because it's too painful, and then they can't have a pap smear because it's too painful, and they can't have sex because it's too painful. And then what we can do, it's not easy to treat. It takes quite a lot of effort and motivation on behalf of the woman, but a combination of sexual counselling, as well as seeing a physiotherapist for what's called pelvic down training. So it's teaching you how to release those muscles and using some dilators as well to help gradually get there, can get you towards sexual function. But a lot of the people I see are just frustrated and just wanting to get pregnant ASAP. And so we can do IUI, so in uterine insemination, under a general anaesthetic, and that's usually very, very successful. From a male's point of view, so if there's some sort of erectile dysfunction or an ejaculatory dysfunction during intercourse, then as long as we can get sperm, we've got the ability to get pregnant. So if we can get an ejaculation, again, we can do artificial insemination, and that works really well. If a man's not able to produce a sample at all, then we can actually do a fine needle biopsy of the testes, which is the same thing we do as if a man had had a blockage for a vasectomy, for example. Get sperm that way and then use that through IVF. Okay, so we've reached our half an hour limit, and I haven't really touched on male factors, and I know my colleague Hassam El-Zaini has gone through them in a lot of detail, but I will just go through it briefly because I think it's a bit rude to talk about reproductive conditions and not include both members of the party. And with men, if you're having sex, there needs to be sperm there. It needs to be of a reasonable quality. And the way that reproductive biology works is that we get one egg, but we get millions of sperm. So we don't have high expectations of each individual sperm. They don't all have to be perfect. You only need a small number of them to be absolutely perfect. And the more you put in there, the more likely it is that one of them is going to be able to get to the egg and actually fertilise it. And what can cause the problems with this? So the main issues and the most severe ones are if there's a blockage. So a vasectomy is one that someone's gone out and had done deliberately, but you can have a blockage there from previous surgery or an infection. There's certain genetic conditions which can cause that, and we can, as long as we can retrieve sperm through a biopsy, then there's the ability to get pregnant. There are other conditions which are a bit more challenging. So if the testis is not producing enough sperm, then some of those are untreatable. So there are some genetic conditions. There are conditions where the testicle starts to fail, so primary testicular failure. So it's sort of like a menopause but for men. And if we can't retrieve sperm, then you would actually need to use a donor for that. And then there are some treatable hormonal causes. So the same as women, thyroid, prolactin, those ones are treatable. And there's a lot of lifestyle factors that can affect the quality of the sperm. And the most common that I'll see is obesity, diabetes, smoking and heavy alcohol use. And those are the ones that are potentially a bit treatable to correct. But the good news with sperm is that if you can get it to a point where you can conceive naturally, that's great. But one of the beauties of IVF is that before we had it and before we had that process called ICSI where you can actually inject the sperm into the egg, everyone had to use donor if the sperm wasn't normal, whereas now we've got that and we've helped people to achieve families using their own sperm with that process. So that's really great. And I've got one last question that I'm going to answer, and again, another controversial area, so I like these questions. So from Kirsty, is DHEA beneficial to help improve egg quality in older women? Possibly, possibly not. So for those who haven't sort of looked at it, DHEA is a precursor to hormones like testosterone. And we do find that as a woman's getting older and as the egg's getting older, that some of these hormones do reduce. Unfortunately, in my experience with it, and I have used it multiple times in women who are older where we're not getting success with the quality, it hasn't been very successful. But I don't think it's necessarily just that. I think that there's just so many other things that are against you in terms of the quality of the egg. If you're getting it, look, they do say that there's natural DHEA in some supplements, and whether that works or not, I don't know. But if you're having prescribed DHEA, it's important to know the side effects and how that can affect you. And it's a precursor to testosterone, so testosterone causes things like oily skin, acne, hair growth around the face. And if that's going to happen to you, then that may not be an acceptable side effect. Is it worth trying? Look, if you've tried everything else and you're wanting to do every last attempt, then I wouldn't have a problem with you using it. And if it works, it works. And if it doesn't, at least you've tried everything. All right. So unless we've got more questions, we might wrap it up there. And I think the really important thing is, and a take-home message in terms of fertility conditions, it's really important to have your own treatment and your own investigations individualised, because everyone's going to be slightly different, and people that you read about who say, oh, I had this, get this test done, have this treatment because it worked for me, that's great because it worked for them, but you might have something subtly different and something else that needs to be investigated and treated in a different way to help you get pregnant. So first step is seeing your GP to get a referral. Second step is getting in to see a fertility specialist who's really interested in investigating you fully, seeing what's going on, and then giving you a full list of options for treatment so that you can tailor your own fertility treatment to what you want to get out of it. All right, so thanks everyone for a lovely evening.